Yeah, so right now is essentially is like speed dating. Think of it that way. So you're kind of checking out preceptors, you're seeing who you like and who you want to ride with, whose medic philosophy you kind of mesh up with. Because there's some people who go and are like really laissez-faire, and there's some people who are super aggressive, and then there's some people kind of like in the middle. And then there's some people who I'm going to tell you absolutely do not ride with. So you kind of have to mesh those two things up. Danielle, you talk. What's up? Hey, how are you? Long time no see in real life or in virtual life. So, guys, this is Paul. He was class president in POC 25. I'm good. How are you? I mean, I expect nothing less from you. I'm good. So, question. We gonna get some ambulance doing any 911 shit lately? We gonna get some yeah? So, like, maybe you want to send me an email? We could talk about maybe getting some rotations up in Orange County. Hi, shoot me an email. I'll send you the good people. Terrible. All right, as I was saying, so and Paul can talk this too. Paul, feel free to jump in. This is your time when you're like you're speed dating, right? You're kind of meeting preceptors who you kind of mesh well with, okay? And when you get to your internship, you're gonna tell them like, listen, I'm in my internship. I'm so like, and you hopefully you have found your medic life partner, and you're gonna say, listen, like, I'm supposed to take the team lead, like, and I don't want to step on your toes, so like, I'm supposed to run the calls, like, is that okay? Like, can we just make that a thing? And then they're gonna expect you to start taking over the calls as well. It's not gonna just be like they're like, all right, medic student, carry this bag. Like, it's gonna be like, you need to be aggressive. You need to be the first one in the door. You need to be the one who's making patient contact, kind of thing. So when you start becoming that person who starts to take over, it'll be okay. And like, obviously you can like say, hey, listen, like, I don't want to step on your toes, but like, you know, I'm supposed to do team leads. And you're like, yeah, of course. Like, you tell me what to do, right? And you should find a preceptor who's going to be like, you tell me what I'm doing, and then you'll be fine. For example, we had a medic student last night on the truck, and he was like, not in his internship yet, and he was like, all right, like, what do you want to do? He's like, let's start an IV. I'm like, all right, cool. I already set you up. And he's like, all right. Like, or okay, what are your different? I may ask him like, what are your differential diagnoses for this patient? Like, what do you think is going on? I'm actually going to use the scenario tonight. It was one of the calls that we had last night, which was like a really interesting call. But you should be progressing as you're doing your ALS rotations, not your internship. As you're doing your ALS rotations, you should be kind of progressing in confidence level, I guess is the best way to put it. So like, as you're like, yeah, no, like, oh, I know what this is. Like, oh, I'm gonna get the IV. We need to do, and like, even if you do something like saying like, we need a 3 lead, we need a 12 lead. Like, can someone get me a 3 lead and a 12 lead? Get me a blood pressure. You're not necessarily being like, you do this, or, you know, like you go grab the AED, come back kind of thing. Like, you're not necessarily doing that. You're working as a team, and which is why we do this kind of period before your internship, so you kind of get to know the preceptor and be like, hey, like, you went through medic school, you know what it's like. These are the things I'm going to have to do. And they'll be like, okay. And if you have the right preceptor, they're going to encourage you to take the lead. Yeah, I can be. So the only problem is I'm per diem at Jamaica, or back at being per diem at Jamaica. So I do not have a consistent schedule. However, I can pop up and like sign your paper. You're going to be I will 100% make recommendations as to whom you should choose. As is evidenced by the shifts from like don't go there at that time. Like but yeah. For the most part. And Paul, if you want to jump in, you have to unmute Danielle's phone. But if you want to jump in and explain a little bit more about how this goes, but for the most part, you're going to choose a truck. And that might be the 5-1 Victor 2. And you're going to then also choose a preceptor, and that preceptor could be Mr. Jose Rojas, who works the 5-1 Victor 2 the majority of the days. So as long as you are on the Victor 2, you are getting hours. 50% of those hours need to be with your chosen preceptors. So as long as those two kind of align, then you're good. So if, for example, if you choose Frankie Filoramo as your second preceptor and Rojas is out that day, but Frankie's still on the truck, you're good for your preceptor 50%. Mm-hmm. Oh, you especially. I would say if you don't do a double, I'm gonna smack you upside the head. You. That's a long drive for not doing a double. Um, yeah. It's true. It's true. And that happens. So, and this is also like if you want to come to me and say like, "Hey, this is kind of my style or kind of how I feel I'm going," I can kind of maybe direct you towards someone who you might pair up with well. Or if you're like, "Hey, I kind of like for example, I know there's a lot of people or I've had medic students who are like, "Hey, I feel like I'm too passive. Can you pair me up with someone who's more aggressive?" So I kind of moderate, and I'd be like, "You need to go with this person," or like, "You need to kind of see how this person operates." So depending on your personality, like I'll do a little matchmaking. I'm pretty good at matchmaking. Not gonna lie. Perfect. Deal. Yeah, I that's okay. That's fine. You're going to have that. I mean, for example, if you want to talk about a good poke the bear story, when I was in medic school, I signed up for the Willie 2-3 on Friday. And I work with a preceptor who is no longer at Jamaica. He was awesome. His name was Matt Groveman. He actually works for like an organ transplant company thing now. Out east people you might have interacted with him. He was fantastic. We clicked really well. We had really good like medic soulmate chemistry, right? Turns out he was in a temp position. So I was so excited that we were like, we meshed and it was great. I went home and I picked up the 5-1 Willie 2. No, wait. The 5-1 Willie 2-3 for the rest of my class. I come back the next week and there was a completely different medic. He came back from being injured, and Matt Groveman was no longer on the ambulance, and this guy hated my guts because I'm like over here like, all right, this guy's a COPD exacerbation. He's like, well, what do you want to do? I'm like, we're going to give him albuterol, ipratropium. We're going to give him, start an IV, give him some fluid to loosen up the junk that's in his lungs, and we're going to give him some steroids. And he's like, we're not starting IV. And I'm like, what? What do you mean we're not starting IV? He goes, it's not sterile. I'm like, I'm not starting it with like a rusty nail. Like it's aseptic. Like, so we did not get along. So I went home that day and I dropped all the 5-1 Willie 2-3s and picked up all the 5-1 Victor 2-3s on Fridays. And I got an email from Scott like, do you not know how to schedule? And I was like, excuse me, sir. I will not ride on a truck with a preceptor who hates my guts. And like, that was the end of that argument. But yeah, like you need to find someone who you mesh with, and I forgot where the story was going. So yeah, he was very angry. He was like, what are you doing? If you don't know how to schedule yourself, I'm going to restrict you to only scheduling 1 month in advance. And I was like, yes. Yeah, for the most part. And there's some stuff that's like over and above, like ICU. Like you guys have to ICU. It's not apparently required like by coamps. It's a good thing to have, and I actually had made the recommendation like 2 years ago, like we should put you guys on a CC truck to see that aspect because it's a little more, and really we'd be doing CC through senior care. And they could not guarantee that you would get a job. So, but I'm like, for the same token, if you're going to an ALS rotation, you're still not necessarily guaranteed a job. Especially in certain days. Like, I can't tell you the number of times where I'm going to work, and you like show up, and you're like, wow, there's nothing happening today. You got all the radios on, you got Queens East on, you got Queens West on, you got PD on, and you're like, no, nothing, no one. Not at all. Nobody. It happens. That's the beauty of EMS. It's like the one day that you don't bring something else to do will be the day that you don't have any jobs. So, and always bring snacks. Okay. You better be. You better be. I'm gonna kick some butt if y'all are not. Okay. Alright. One thing, because, Soraya sent me the review sheet that you guys are doing, and I looked over it real quick. You guys look like you're on the right track. Number 14 on the list is, like, which is least likely to get frostbite. Yeah, but think broader on that one when you look at your options. So like for example, if like the core is an option, that would be obviously the more correct answer. All right, just keep that in mind, I guess is the, there you go. Okay, good. No, because I know there's some people who are very single focused. Let's go with that. You know what I mean? So I don't want anybody to be, yes, Matt. I don't want anybody to be misled down an inappropriate serpentine path. And by serpentine, I mean the devil. All right, cool. Any other thoughts, questions, or concerns before we move on to a quick... This is actually the call we had last night that I was like, ooh, this is going to be so good for review because it's complex. Anybody? No? This is BYOB. Danielle gets a pass because she's at work. Also, Matt gets a pass because he's at work. Ashley gets a pass because she's at work. Okay, go ahead. Go ahead, go, no, go ahead. You have the better. Yeah, go. Oh, you. So basically what we're doing right now is probably going to afford you, well, you need to know your protocols. And just from the experience of actually being somebody, I was at Jamaica. They had a medic student who was going for her upgrade, and she could not do her protocols. She had no idea. That's going to jam you up. Like, she's not getting an upgrade because she just didn't know her protocols. And we'll talk about, actually, you know what? Let's talk about that right now. All right. So you get called to a scene of a patient complaining of not feeling well. Comes over as an anaphylaxis. When you get on scene, you notice that the patient has has swelling to like the TMJ area, or the jaw area. Otherwise is in no distress. Patient states that. So wait, this is Tuesday. Okay, so Friday, she went to the dentist, or she started having tooth pain. And she went to the dentist on Monday, and they said, you have an abscess. We need to treat it. Here's an antibiotic, and here's some hydrocodone, because why not? Let's give everyone hydrocodone. Opioid crisis. I don't know what you're talking about. She took the medications at night. Made sure that she took the antibiotics on a full stomach, right? Because antibiotics, remember, will cause GI upset if taken on an empty stomach. And started feeling unwell. She started feeling a little short of breath, a little nauseous, right? Just to kind of like general malaise is probably the best description. It did not go away 12 hours later. How would you treat this patient? With food. Vitals and fluids. Okay, perfect. Blood pressure is 130/80. Pulse is 90. Respiration's 18. SpO2 is 99% on room air. Okay. 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 Mm-hmm. Wait, hold on. We have to celebrate Danielle's. This is a side effect of taking a narcotic. All right, wait. So wait, be kind, rewind. So what are some other questions that you would potentially want to ask this patient to rule out an allergic reaction or anaphylaxis? 12 hours ago. No. No. Just the antibiotic was ceflexin. Hold on. Y'all stepping on each other. No. No, she's never taken any of these medications before. 48. Sure. Nope. Nope. Old standard. It was this morning when she tried to take the second dose of antibiotic, but she was so nauseous that she did not take it. Sure. Antibiotic and the hydrocodone. So, but let's go back to questions that you would ask the patient in regards to allergic reaction or anaphylaxis. Focus in on those for now because I really want to hear those questions because there's like a set of about 3. Difficulty breathing. What else? Beautiful. Hives. Perfect. Yep. These are questions. Yeah, these are just the questions. She did not have any of these. Perfect. Wheezing. No wheezing. What else? No, she's not hypo. Exactly. Perfect. Right. Not hypotensive. How about you're over here, so yes, not considered anaphylactic. How about trouble swallowing? Right? She could. So it was top jaw. I will say that the abscess tooth was top jaw. How about, so she also had facial swelling on the one side. What other things would you want to ask in regards to that facial swelling? That's a good like wellness question. But yes, absolutely. Good. They did an x-ray. They identified the abscess. They did not remove the tooth because they wanted her to complete the antibiotic regimen first. It's just an abscess. It's an infection. That's it. An infected tooth. Yeah. A nasty taste in her mouth, which is probably yeah. No. But like wait. Let's focus back to the anaphylaxis allergic reaction side of things because this is going to be like that make or break moment when you're on your rotation and you're like, "Let's give them Benadryl," and your medic is going, "No." Perfect. Good questions. It's a very strong possibility, and it's also a strong possibility that it could be the antibiotics as well. Because if she's like nauseous and kind of queasy, antibiotics do that very commonly. Joe, go. Yes, you're not wrong. However, it's not to the point where you would necessarily administer it. I mean, she'd be really sleepy if she was kind of a pain in the ass. Like, yeah, let's give it a shot. But she's a delightful lady. Yeah. Wait. You're breaking up. Say it again. never taken them before, so she doesn't know. First of all, she's on the second floor. So you will not do that until she walks down to the ambulance. Yes, she can, and she did. But going back a little bit, this lady had a very swollen face, okay? So trying to rule out angioedema, say, hey, is the swelling, when did the swelling start? And she said to us, hey, the swelling started when I started having tooth pain. Not when she started taking the new medication. It was when she started having tooth pain, which is indicative of that's the abscess in her jaw. Has it changed at all? No. Right? No, the swelling's been about the same. Perfect. Because if all of a sudden her face goes from being like a little swollen to be like really swollen, then that's a problem. She did. Right? So that instantaneous kind of chipmunking is a problem. But if it was something that was like pre-existing before she started feeling nauseous and queasy, different story. Nobody gave Epi. Nobody gave Benadryl either. No, it was a medic upgrade, and she wanted to give Benadryl, and she was not allowed to touch the med bag for the rest of the tour. No. It's just not sourcing. So what? All right. So, and this is that little shout out I threw out to the group earlier in the week. Sometimes you don't treat. Sometimes all you do is go to the hospitals. Sometimes jobs come over, they get up triaged to an ALS level that are really just BLS. And that's okay. But you need to be able to realize that, like, hey, this is a BLS job. Let's just do it BLS. Does that mean that you don't start an IV and maybe give this lady a little fluid to flush the medication out of her system? Absolutely not. Totally do it, especially as a medic student. That means that you got your skills for the day. It's an ALS team lead. You are golden, right? But when you're looking at it from a bigger picture, she honestly didn't even need an ambulance. She really should have gone back to her dentist and said, hey, like, this medication's making me feel like crap. Like, what else you got? And she would have been A-okay. So what would you have given for the nausea? How much? Mm-hmm. Perfect. That's all you need. And if you're feeling really nice, Zofran's fantastic. People love Zofran. Zofran's like a super popular medication. Yep, so if you want to really make this a ALS team lead, that means that you have to do a 3 lead for her, which means that it's really going to count. Not a bad thing. Yeah. All right, ready? Here's the literally it's not a bad thing to do. You're like, as I said last week, I don't know if you were here for last week, vomit, vitals, O2, monitor, IV, transport is pretty much the best course of action for like 95% of your patients. All right. Vomit. It's great. Everyone loves it. All right. Last call of the night last night. Once upon a time, EMS was called to the AMS. Upon arrival, a 50-year-old female patient was found seated on the bottom steps leading up to her apartment. Patient states she was not feeling well, so she came down to get soda and got so short of breath that she needed to call 911. Patient did not fall down the steps. She sat down on her own volition. First impressions from the door. Patient is in moderate respiratory distress. She is very pale, and she has +3 dependent edema to the bilateral lower extremities. She states that she has been vomiting black-green material for approximately 3 hours and has felt weak and dizzy for the same period of time. States that she has not been feeling well lately, but was unable to go to the doctor. Denies any recent illness otherwise, no fever, cough, etc. States she is compliant with her medications, and she is cold and clammy to the touch. Only history is diabetes. She takes insulin and metformin. Her allergy, she has no allergies. Initial blood pressure is 80/30. Respiratory rate is 28 and shallow. Pulse is 114, and SpO2 is 98% on room air. So, based on that, give me your initial differential diagnoses. What else? Okay, so green bile is also green. So this is a great opportunity for you to ask, when's the last time that you ate? What up? What else? Anything else? What was about a bowel? Danielle, go ahead. That was adorable. Darn it. She vomited probably about 500 milliliters of fluid. Good, right? So we're recognizing that this right here is your main life threat, right? So, hold on, let me change colors. All right. What is your initial approach to this patient? What do you want to make sure that you do? Okay, position of comfort. What else? But PPE, yeah, sure, absolutely. You're 100% PPE'd. Yeah, that's good. All right, airway. Is there anything specific you want to do for airway? No cough. All right, what are some complications if you have a vomiting patient? Sorry, hold on. Vomiting patient and an NRB. Yup. So maybe starting with a nasal cannula in the event of vomiting. If she is not, or what else would you do? Yeah, it's in between. So you could BVM if you wanted to. I know we give that number in the textbook. There are times when patients who are like perhaps agitated or upset, who might be breathing at like a 28, where you're like, do I want, like, maybe you could talk to them and calm them down. How about some psychological first aid? Psychological first aid. Let's hold on, go back to that real quick. So she's complaining, or she's in moderate respiratory distress. Wow. So don't get distracted by your call type. What do you want to know first? Now, go back, be kind. We're over here in AMS. Yes. GCS is 15. Lung sounds. Perfect. Hold on. Hold on. We're going to go to lung sounds first. Lung sounds. Diminished at bases. Unclear. Diminished, maybe crackles. So yes, 100% good catch. Blood pressure way too low for CPAP. Fantastic. Good catch. Cold sepsis. Hold on. I'm going to throw that on your What else? She's able to sit up and she's maintaining her airway appropriately. All right, so let's talk about. Hold on, let me get back to pink. So you want to do an IV. All right, what else? Please and thank you. Yep, 250, perfect. Start with 250. Let's go back to our vomit real quick. Before you do that, what do you better do this M step. Monitor. Because, right, if you're going to give her Zofran, right, you want to make sure that she does not have a prolonged QT. So before you administer medications, we're adding another step to the 6 rights. So, right, so you want to ask if she has any allergies. Just because she says, oh, I have no allergies, does not necessarily mean that she doesn't. Have you ever taken Zofran? Are you allergic to Zofran, right? And you want to get her on the monitor to make sure that she does not have a prolonged QT before you administer. 3 lead. Sinus tack. Just sinus tack, no irregularities, no aberrancy. Correct. And you will see there's no hives. There's no urticaria. Okay, so the blood pressure after the bolus is 110/70. It's working. But going back to our treatment, what else? Someone had said, what's her blood sugar? Oh, here's 6. Her BGL comes back as high. And high on this glucometer is over 600. All right, so hold on. So before we do that, let's go to the protocol. So which protocols are we working under? Are we working under sepsis or are we working under hyperglycemia? I'll go pull up the Can you have hyperglycemia in the presence of sepsis? All right, so let's talk about this real quick. They do. It's wonderful. It's like peanut butter and jelly. All right. So if you look here on your come on, give me my pen. A little sluggish. If you look here on your protocols for hyperglycemia, so patients with a come on. Oh, it's being sassy. Can you see the protocols on your side? No? Alright, hold on. Let me see if I can, because I have it up as a split screen. Come on. It's going to make me stop share and then reshare. Alright, so if you look here in your protocols, you have for patients with a BGL above 300, what you're going to do. So, adult patients, you're going to give up to a max of 1 liter of fluid. Okay, and this right here, this is super important. Accurately document, from a QA/QI perspective, accurately documenting how much fluid you've administered, essential. You don't want your QA/QI coordinator to be like, excuse me, your documentation sucks. All right, so you got 1 liter of fluid here in your hyperglycemia protocol. Now, if we go to the sepsis protocol, I get my little pen. Say that again, Danielle. So when you are working under the sepsis protocol, the patient needs to fit into certain criteria. So it's like their temperature, their BP, the high suspicion, I'm getting there, of an infection, which if you have a patient who's diabetic, you should absolutely be like, I have a high suspicion of an infection. But if you look here, they want you to give 2 liters. Keep that in mind, because that's going to be, when you do your REMAC test, they will ask you specifically which protocol allows how much fluid. Excuse me. So just keep that in mind, okay? That's one of those things like the hyperglycemia protocol, your sepsis protocol, your trauma protocol. These are all protocols that they're going to be like, well, how much fluid are you giving? And you'd be like, I don't know, a lot. Minimum is 1 liter. All right. Hold on, I'm going to switch back to there. All right, so now we have this lady. We have determined that her blood sugar is high. What are some of the questions that you might want to ask to, when did you last eat? Perfect. So she ate at around 3, and then she vomited it right back up. Insulin was also was around 2. But how, like, wait, sorry. Questions that you're going to say, hey, DKA versus sepsis. And what other physical assessment things would you do to kind of determine the difference? Not that you can detect. Sepsis sometimes has an odor also. I don't know what it is because I can't smell. So for fruity odor versus a sepsis odor. No, but she's no fever, but she is cold and clammy. The blood pressure, yeah. So her blood pressure at 80/30 could be either. It could be either or. So that's not really unfortunately not a super helpful. Yep, Kusmos. It's a possibility. It's a possibility. However, when you also have patients who are in sepsis, as they start to get acidotic from the sepsis, their respiratory rate also goes up. Yes. Byproducts of the one, byproducts of the bacterium. Two, your body releases increased cortisol in order to fight the infection, and as it increases, cortisol creates a release of glycogen from the liver, so your sugar will go up in the event of sepsis. Yeah, no, absolutely. That'd be great. So what are some other questions that you might want to ask? How long is what, Joni? Surgeries. What else? No. Good question, but yes. Yeah, the answer is no. No, the answer is no, not don't answer. It's a good question to ask. Good. Okay, so abdomen. What else? In diabetics, what's important to look at? Where? Das toes. Good. Always check the toes. Toes are always the source. Almost like 96% of the time. Good, good. Ask about that pedal edema. It might be. It's a possibility, but you'd be hard pressed to justify that through protocol. Mm-hmm. All right, good. So you got no distension. Or no other abdominal discomfort. Yep. Positive bowel sounds. Correct. Yep, so the 1 liter of fluid is up and running. Well, her blood pressure is going up, so that's good. She's feeling a little bit better. What other things do you want to make sure that you're checking during that period of time? Breathing and lung sounds. Lung sounds are essential in this right? Once you start giving fluids, your lung sounds, well, you don't have a liter of fluid in because your partner drives fast, and by partner I mean me. So you got to the hospital with probably about 100 cc's have brought you from 80 over 30 to 110 over 70. Lung sounds are still good. There's no positive or negative change. Yep, so your heart rate's coming down a little bit. Okay. What are some EKG signs that you might want to be looking at? No, you're good. You're good. Peaked. I think that what you're looking for is it peaked? Yes. And what does hyperkalemia indicate? And what is that usually associated with? Go back to your patient's history. In patient's history, she's a diabetic. That's it. That's true. So we talked about this back in the metabolic emergencies, right? DKA versus HONK, right? Hyperosmolaric.
Hyperosmolar non-ketotic.
Non-ketoacidosis, thank you. Right? The difference between the two, right? You have the hyper K versus not having hyper K. Also, sepsis, if you don't have any EKG changes, sepsis still plays into that realm of possibilities. If there's no hyper K. So these are a lot of the things that you're looking for. And this is just breaking it down because, like, as you're doing it or as you're assessing your patient, a lot of these things should be coming to you, right? So, like, and you might not even be aware of it, right? So you put the 3-lead on, you see like a completely normal looking EKG, and you're like, all right, she doesn't have PT waves, so it's probably not DKA. It's true. Well, you can have the hyperosmolar non-ketoacidosis where they don't have the hyper K. So yes, you could still have someone who has a blood sugar in, like, that's considered quote unquote high, who isn't necessarily in DKA. Is it safe to assume that there's a strong possibility of DKA? Absolutely, when you don't have the ability to do an EKG. When you have the EKG, you can confirm your assumptions through a peaked T wave. But she did not. You can pretty solidly say that she's probably not DKA, but that does not necessarily mean that she's not in HONK, right? And that's a type 1 type versus type 2 diabetic issue. A 100%. So you're going to do 2 liters in sepsis and 1 liter in hyperglycemia, right? Doesn't matter what flavor hyperglycemia you have, if it's DKA, HONK, or just your run-of-the-mill extra sugars. Of insulin? At this point, no. Once you kind of come into being the primary care person for the patient, you don't necessarily want them to give themselves insulin, because if they give themselves a large bolus of insulin, what potentially could do is you swing them the other way and you create extreme electrolyte imbalances. Because even in the hospital, when they start treating these patients, when they treat patients who are in DKA, what they'll do is they'll actually give them sugar while they're giving them insulin to balance the electrolytes so that they don't swing into DKA. She got enough of that. Mm-hmm. A lot of chemistry. So what is there anything else that you obviously we said now Zofran and we said liter of fluid and we said monitoring. Is there anything else that you want to do for this patient? And just because I asked this doesn't necessarily mean that the answer is yes. Usually calcium. Calcium is the buffer for potassium. Yes, and we don't have a peak T wave. So if you had peak T waves, you could call and ask for bicarb and calcium. If you do not, then it's gonna be a little harder of a sell with medical control. Yep, albuterol is fantastic for putting potassium back in the cells. I agree. I think you guys covered pretty much all you're going to be able to do. Exactly. Exactly. And honestly, if you're in most places in New York State, or at least in the metropolitan New York area, you're probably about 5 to 10 minutes from the hospital. You're going to have a hard time flashing somebody in 5 to 10 minutes. So at the end of the day, this lady, her blood sugar was 896. Yeah. She was a little confused. She wasn't like really out of it. Like she could answer her questions appropriately. She could tell you what's going on, but she was a little dazed looking, I think is the best way to describe it. And the most heartbreaking part was that she didn't want to go to the hospital because she didn't want to leave her dog home alone by itself. Yeah. You guys saved your first patient. I'm very proud of you. Yeah, Girardi, it's a Hasola truck. Well, that's it for tonight. So, yeah, that's it for tonight. One at a time. Well, I gotta pace y'all out throughout the rest of your internship. I gotta come up with really interesting calls. So that means a lot of like flipping through the mental Rolodex of all the good jobs and hoping I didn't use them as an example during a lecture. You're welcome. Yeah, not a problem. All right, sounds good. I will send a like a text out to the group and with the, hey, is everyone available for this? And we'll go from there. All right, keep me updated also if you guys have interesting calls on your rotations, and be safe. Wear it at 95 is good for you. All right, guys, have a good night.